You're built for certain things. You should definitely try and find the thing that you can put the effort into. My name's Kate Drummond and I'm a neurosurgeon at the Royal Melbourne Hospital. A lot of people come to me and go, I'd really like you to mentor me, and I'll give them a project to do. So it's a two-way street.
Yeah.
You don't just turn up and say, I'd like you to mentor me. You've got to show your value in the relationship. In the 50s. If you're a really smart woman, you are unlikely to be partner in a law firm, head of a department of neurosurgery, or a fighter pilot.
What's within our control to making a small change and fixing the problem?
I don't think we should make a small change. I think we should make a very big change.
How do we do that?
Well,
with surgeons, there's always a risk. How do you contextualise that risk and still move forward?
For me, risk is, I've got photos of patients who've died, particularly people who I've looked after for a long time. There's, one particular couple, and there's a picture of him and his wife in front of the Eiffel Tower, all lit up, and it's lovely. And I look at it and I think, when I'm I'm not really having a bad day.
Yeah.
Not really. I'm okay.
Yeah.
It's a bit busy today and things are a bit stressful, but I'm okay.
Hi guys, quick one. A small favor I want to ask from each and every one of you, if you're enjoying the episode that you're currently watching, is to subscribe to this YouTube channel. It goes a long way in supporting our vision of the podcast, where we want to go, the guests we want to talk to, and your simple gesture of clicking subscribe is the biggest favor you can do for us. So if you could do that right now, that would be awesome. Thank you so much, and back to the episode.
Now, Professor Kate, your bio is
Yes.
very long.
Yes.
And I'm just going to read it out for the context for the audience. You've published over 180 peer-reviewed papers. You're co-editor-in-chief for the Journal of Clinical Neuroscience and on the editorial board of the Journal of Neurosurgery. You served as the chief examiner in neurosurgery for the Royal Australasian College of Surgeons. You're a chair at Pangea Global Health Education. You've been awarded the member of the Order of Australia, and you're the head of Department of Neurosurgery at the Royal Melbourne Hospital.
Yep.
In your own words, what do you do? Because obviously you don't say this to everyone. What do you do in your own words?
Well, I'm a neurosurgeon.
Okay.
I specialise mostly in brain tumours, but I do some general neurosurgery. I lead the department and I do quite a lot of research. And I have some other interests outside of work, which include Pangea, which is still just an extension of it because it's medical education in low resource settings.
Yeah, and is that more public health or clinical for clinicians?
No, for clinicians, and it's critical care and surgical education sort of focus.
In normal people talk, in something that I would understand, what are the types of patients that you would see regularly?
The two most common would be patients with brain tumours of all sorts. So that could be benign, surgically curable to, the terrible cancers. I see some spinal surgery. I don't do the really complex spinal surgery, but there's plenty of straightforward spinal surgery that I do. A little bit of surgery on peripheral nerves, so nerves outside of the brain and spine, and a little bit of trauma because everyone does some on-call. They're the main things.
Perhaps take us to your upbringing. Where did life start for you, and could we find any clues along the way of Professor Kate, the neurosurgeon?
So I'll tell you now, there's no clues.
Okay.
I had a really pretty standard upbringing. I grew up in Sydney. The first 5 years of my life were in Cogra in Sydney, and then I went out to a suburb called Westlea, which at that time was sort of the edge of Sydney, but not anymore. I went to regular public school, regular high school, regular parents. Mum was a music teacher. Dad, started as a draftsman, but then went into fixed fire protection. Younger brother, younger sister, Probably the only unusual thing about my upbringing was I was adopted, but that wasn't really a big deal for us. And I just enjoyed school, but thought, towards the end of school, I probably could have gone into teaching, science, medicine, law, anything. I hadn't really decided. I just thought I'd go to Sydney Uni, so I applied for all of those things at Sydney Uni.
Yeah, and what made you decide on medicine? Was it?
I got in.
Okay.
So I literally applied for law, science, medicine, teaching, and I don't know what else, something else at Sydney Uni, because I wanted to go to Sydney Uni because I like the buildings.
Sure.
So I wasn't particularly wedded to anything. I mean, I'd been told, if I worked really hard in my final year, I could get into medicine. So it's like I was interested.
Yeah.
But it's not like I was one of those people who applied everywhere to get into medicine.
Or like you grew up always wanting to be a doctor since young. Yeah.
No.
Was there any alternative careers that you could have been on, like as you were growing up, you've always wanted to be this or that?
Well, in year 10, I wanted to leave school and become a hairdresser.
Great.
I thought that'd be quite a good trade.
It's basically surgical procedures with hair.
Yeah, just hair. That's right.
Is, yeah.
Just on the outside.
Yeah.
But clearly I stayed. My mother's very smart, and she managed to persuade me to stay, basically with reverse psychology, by saying, "Sure, be a hairdresser." And I'm like, "Yeah, okay, I'll keep going at school." So I was interested in hairdressing, and lots of things along the way.
And once you got into medicine, was medicine what you expected?
No.
Was it better or worse?
Worse.
Okay.
The first 3 years were awful. Okay. Awful. I hated it. I think every exam I'd come home and I'd say, "Oh, I can't do this. I hate this. It's awful. It's just rote learning and I'm going to fail." And, my mum would go, "Don't worry, stop studying. Just sit the exam. If you fail, it doesn't matter. We can do something else." So I'd sit the exam and not fail and keep going for another day. And I really didn't enjoy the first couple of 2.5 years. It was when I started seeing patients that I really started to enjoy it.
What changed once you started seeing patients?
I saw sick people and I thought, well, I can, this is good. This is what I'm here for. I wasn't really here to learn about the, digestive system of a caterpillar or whatever else they were teaching us in comparative biology or physics.
Is that really what you learned?
You had to do this awful subject called comparative biology where you learn about exoskeletons and endoskeletons and hydrostatic skeletons and all this weird stuff, and it's like, okay, well, it's kind of interesting, but I'm not sure it's getting me.
Yeah. Wow, that is funny.
And then, we had to do anatomy and that stuff as well, but I didn't enjoy it when it was sort of disconnected from the patient.
Yeah. Now, just as you were saying that, I'm noticing that mum's parenting especially is quite encouraging.
My mum and dad.
Mum and dad.
And mum and dad.
There doesn't seem to be much pressure. It's, you do you.
No.
Did that help, the lack of pressure and just letting you make your own decisions and find your own way?
Yeah. I mean, they were supportive of whatever I wanted to do. They just wanted me to be happy.
Yeah.
So, I mean, they like it that I've done well and they like it that I've tried hard, but they would have been very happy with anything that I was in that I was enjoying.
And did you work harder because you enjoyed it?
Oh yeah, I worked really hard.
Okay.
Probably not the early part of medicine, I didn't enjoy it. I found it really hard to get down to studying. But ever since I really started to enjoy it, I've worked really hard. We'd go out to parties and all my friends would still be partying, and I would, at 11 o'clock, 12 o'clock, find a quiet room, start studying while everyone else was like getting wasted or whatever. Yeah. So I worked really hard.
And what was it about you that did that?
Who knows? I don't know. Because it's interesting. It is interesting to me that people are built for different kinds of hard work.
Sure.
So I thought that I'd like to be a musician, but I'm not built for practice.
Sure. Yeah.
I played the violin and did all that badly.
Yeah.
And there are other people who can get up at 5 o'clock in the morning and practice for 2 hours before school and da-da-da-da-da. Couldn't do that.
And that's so interesting that we should be finding our lane, and it's really hard to find our lane if we're pressured into doing one thing or another, right? But you fell onto medicine because you enjoyed it. Well, because of the buildings first in Sydney Uni, you enjoyed it, and then you found it almost easier to work hard in medicine
Yeah,
compared to something
it's
else?
not so much easier, but you're built for certain things, and
Yeah.
you should definitely try and find the thing that you can put the effort into.
You've obviously done very well, and I would say that your reputation sort of precedes you, because I told my wife, I said, hey, I'm interviewing Professor Kate Drummond for season 2, and she goes, oh, really? I'm like, what, do you know her? I was like, yeah, everyone knows her. I'm like,
I'm not sure that's a good thing.
okay, well, I didn't know about her until I heard her TED Talk, but tell me more. And then, so she spoke to a few more of her medical friends and said, isn't she the neurosurgeon? She, and the overwhelming response I had was, wow, she's so inspirational. She's leading women in medicine and all that sort of stuff. So you've done very well. And I think among your peers, whether you know them or not, because you probably don't know most of them personally, I think what you've done in your story has certainly inspired a lot of people. I guess on that note, one big thing that I hear about is women in surgery. Mm-hmm. There's not a lot of women as surgeons.
Yep.
Why is that?
Oh, look, there's lots of reasons. I mean, it's rooted in assumptions about gender roles long time ago. Then, we managed to sort of fix that in medicine in general. I mean, for a long time, there's been equal numbers of women and men in medical school. And in fact, probably more women than men in some medical schools by a small margin. It's translated well in some specialties. Obstetrics is almost entirely a female specialty now. But for surgery, I think it's about ways of working, about perception, and about culture.
Okay.
And yeah, it's a really hard nut to crack, because people will go, because it's like really long hours and there's lots of emergencies and women want to have children, but that doesn't make sense, because obstetrics is like long hours, lots of emergencies, and women want to have children.
Right.
And yet they've managed to, transfer, that to still attracting lots of women. Surgery, has just worked a particular way for a long time, and I think it really puts talented women off wanting to do it.
Is there a certain part of surgical culture that you feel does that?
I think there's lots of things. I mean, part of it is the way we work. I mean, we work very hard, and we're all overcommitted, and you feel quite responsible for patients you operate on. So more group ways of working or more sort of shift work often doesn't sit well with surgeons, although whether or not you can work that way, I think, is unexplored. Once you get a whole bunch of high-power blokes in the room, the culture is completely different, and that's not always so welcoming. It wasn't a problem for me. I can give as good as I get, but if you're a bit more timid, or it may be a problem.
And other professions are less like that?
Oh, no. I think it's probably the same in engineering.
Sure.
I think, it's probably the same in a lot of the STEM subjects. And also, if you haven't got a lot of welcoming women, I think it's hard. And it's hard even to be one of the few women and be welcoming to a whole lot of people who want to come in, because it might either mean you're mentoring, you're overcommitted to mentoring because you're the only person available to do it. There's a little bit of science behind, if you're the only person, if there's only one place at the table for who you are, i.e. your gender, then you might want to protect that place and not have people come in to take it.
Yeah.
I think there's a myriad of reasons.
Yeah. And what do you do, or what's within, I guess, your control, but also maybe the listeners, what's within our control to do our part in making a small change and fixing the problem?
I don't think we should make a small change.
Okay.
I think we should make a very big change.
How do we do that?
Well, so we accept people into neurosurgical training by defining a standard.
Yep.
So we decide you need to do X, Y, Z, and Q to be a neurosurgeon.
Sure.
there will be equal numbers of men and women who will meet that standard. But it's not a level playing field to even getting to the point of applying. But I definitely think that once people apply and are shown to meet that standard, we should preference employing women over men every time until we reach 50-50. It's to socially engineer a 50-50 mix.
Do you think, I don't know if there's stats for this, but do you think out of everyone that wants to be a surgeon, 50% are women, 50% are men?
No, they're not.
Okay.
They're not, because it's not a welcoming profession, and it won't be welcoming until we engineer it to have more women in it. So they can see not just overworking childless freaks like me, but, you know, a broad range of women who have families and who, you know, do all the things that the broad range of women and men, also minorities of men, do. And, you know, you might think that what I'm saying is a quota. That's not quite what I'm saying. What I would say is, say in neurosurgery, there's finally 24 people who reach the final cut to apply for training in Australia and New Zealand. There might be 6 or 7 women out of them. If each of those women meet the minimum standard, even though we rank them and we say, you know, man number 1 got X 0.1 points and man number 2 got X 0.2 points and woman number 12 got however many points, even though we rank them, the ranking is kind of meaningless because they're all sort of equivalent. You know, the difference between those, they're all good enough. So all of the women on that list should be employed first as neurosurgeons. That's a very unpopular view because it means that all of these other, and then once we've got equity, I'm happy to go back to a ranking.
Yeah, right. Yeah, it is a bit like that because you can see the other side of the coin, which is the men going, well, if I'm ranked higher, is it because that I'm a man that I'm being discriminated against? But like you're saying, the problem starts even before people apply. Because perhaps there were women that could have been brilliant neurosurgeons that just never applied because they just thought, no,
been put off by the culture, they've had a bad experience in theatre with someone or whatever. So until we engineer, and we've done decades of mentoring and role models and, you know, all of that stuff, but it's moved the dial like by a few percent. We're not, you know, there was a paper that me and another neurosurgical trainee wrote an editorial on, where in America they worked out it's going to be 156 years, given current trends, for there to be gender equity in neurosurgery.
Okay.
So
generations.
we need to probably work a little bit harder on that. I'm not big on just sort of dancing around the edges. I really think that we need to work harder. I'm not asking for quotas where you say it has to be this many people. I'm asking us to preference all qualified women. And remember, if you're in the majority, equity seems like discrimination.
Well, okay, here's another point of view on this. So Jordan Peterson says men are generally more interested in things and women are more generally interested in people. And I don't know how we quantify and measure that. Which is why, generally speaking, that's his reasoning of there's more male engineers and more female nurses, right? Because women are more caring and nurturing, whereas men are more like, let's build crap, right? Could there be just the simple fact that less women are interested from the onset? Going into medical school, perhaps more women want to be...
There's a little bit of evidence that would suggest that at the beginning of medical school, there are equal numbers of women and men who are interested in surgery. It's not probably locked in stone. But remember, things like nursing and teaching, they were the only careers available to women for hundreds of years. So, of course, they're going to be seen as being women's sort of professions. But, you know, so even say in the 50s, okay? You've seen the movies made about it and whatever. If you're a really smart woman who wants a career, you could be a headmistress or a matron. And that's fine. They're fantastic professions.
Yes.
But you are unlikely to be partner in a law firm. head of a department of neurosurgery, or a fighter pilot.
Yeah.
So we have some pretty ingrained sort of stereotypes.
Yeah.
We saw, things like the world wars or whatever. We've seen women do all sorts of things and then be chucked back into their corner once the men came home.
Yeah.
I would challenge that there are particular professions that are really more favoured by men or women if it started with a level playing field.
If there was a young medical student, female medical student, who said, I'm inspired I want to be a surgeon. Okay. And at this point in time, culturally, that's more difficult for her to make it to the end. What are some of the things, micro, so not the macro, but the micro within her control, that can help her get to the final destination?
Well, I mean, the path's all mapped out. It's there on the College of Surgeons website, what she has to do.
Yeah.
And so she has to, forget about all the naysayers and everything else, put her head down and work hard at doing the things that she needs to do to get onto training. And, keep an open mind. Is this for me? I mean, it might not be for her. Find someone who will be supportive and not just mentoring, but also sponsoring, so giving you opportunities.
Right.
And that doesn't have to be a woman.
Yeah.
I just say go for it.
Yeah. How does one find a mentor or a sponsor?
You look out for them.
Okay.
And you latch on. But, the mentoring or sponsoring, it's a two-way street. A lot of people come to me and go, I'd really like you to mentor me. And I'll give them a project to do. If that project is not finished on time,
sure,
within reason, etc., then you sort of, so it's a two-way street.
Yeah.
So make yourself useful as well. Make yourself stand out. Make yourself, you don't just turn up and say, I'd like you to mentor me. You want to find someone who you can work with, show them you're a good worker. You've got to show your value in the relationship.
And that reminds me of a story I heard about you in the Journal of Clinical Neuroscience, where you started off as
save me, the language editor.
The language editor. That's a great example, isn't it, of you just doing the work and showing your value, right?
Got told that was my job. At that time, the journal was just starting out. So, so you accept basically a lot of case reports, which we don't even accept anymore. Yep. A lot of case reports, often from people whose, English is not their first language. But so we're grateful for the submissions, but they're not, the content might be good, but the quality of the writing is not great.
Yep.
So it was my job to make it better.
So translating it.
Well, turning it into scientific English, grammar, syntax. And remember, this was at the time where there was no online editing. So it was correcting a paper version, which sometimes there was not enough room on the paper for me to make all the corrections. So I'd send off the first round and get it back for the second round.
Wow.
That was a labour of love, let me tell you.
Wow. And that's where you started in the Journal of Clinical Neuroscience. Where are you now?
Yeah. Well, I'm the editor-in-chief. So, I've been associate editor, I've been neurosurgery editor, I've been, all of those things.
Amazing. And I guess with every profession, there's your core practical skills. So being a surgeon, your ability to perform the surgery. And then there's also some of the soft skills, such as finding a mentor and, like you said before, ignoring all the naysayers and all that sort of stuff. How important are the soft skills for a surgeon?
So they're as important or as unimportant as you want to make them.
What do you mean?
So I'm a surgeon who deals a lot with people with brain tumours. These are people at the worst part of their life. The soft skills are incredibly important. If you can't, communicate reasonably well, have some empathy, give people, options for their treatment and in their lives. If you can't do those things, you shouldn't be doing that sort of surgery. But if you're an orthopaedic surgeon who fixes broken bones, sees the patient once and then lets them go, and that's what you want to do, and that's what you're comfortable doing. And I mean, it doesn't mean they've still got to be able to take a history, get a consent, be a good person, but that sort of long-term relationship communication is very different. Different soft skills if you're a paediatric surgeon than or different soft skills if you're a cosmetic surgeon. So they're important, but I think they're all different depending on what you do.
And what about in terms of career progression? So if I'm perhaps a more timid young doctor who wants to be a surgeon but finding it a little bit more intimidating, the culture and everything, is there a way I could improve my soft skills in terms of networking, reaching out to people, ignoring naysayers, all that sort of stuff? How would I?
Well, every junior doctor works in a team.
Okay.
I mean, so my team, we've got 12 residents, 10 registrars, 3 fellows, 16 neurosurgeons. So there's a team of more than 50 people.
Yeah.
You'll find your allies in amongst that.
Yeah.
So I think, getting to know people, finding people who you can work with, be encouraged by, be mentored by. I think that's looking around and working out who's around you.
And just taking those opportunities when they come.
Take opportunities. But, if you're super timid, you're going to have to get over it.
Yeah.
You're going to have to, learn how to present yourself in a somewhat confident way. And I guess, people even do coaching for that.
Yeah.
But it's not just, that's not just for networking and those sorts of things. I mean, if you're going to look after patients, you've got to be able to present yourself in a confident way. You don't want to go in and say, "Hi, Mr. Jones, I'm Dr. Drummond and I'm going to do your operation tomorrow," and you're not looking confident about it. You've got to look moderately confident.
Yeah.
Honest, but moderately confident.
Sure. And having some potentially confronting conversations too, that won't be easy.
Every day.
Right? Now, Kate, you are the self-appointed Antichrist of work-life balance.
Yes, correct.
What do you mean by that?
Oh, it's a silly throwaway line that I added to a talk once when people asked me to talk about work-life balance, and I called them. It was a college, and I called them up. I said, "Are you sure? Did you get the wrong name? You want me to talk about work-life?" And they're like, "Oh yeah, we really want you to." And I thought, and you sort of, I'm like, I'm the Antichrist of work-life balance. I kind of believe a little bit more in, well, at that time I was thinking work-life continuum.
Right.
That work and life, the idea that work and life are separate is incredibly unhelpful.
Sure.
Number one, I see so many young doctors thinking, "Oh, I'd really like to be a surgeon, but I'm very worried I won't have good work-life balance." And I'm like, okay, so what is work-life balance? And they're like, well, work and balance and life. And I'm like, what does it actually look like? Does it look like working 9 to 5 and having the rest of the time to doom scroll on the couch?
Yeah.
Does it look like working 6 to 6 but having weekends off? What do you want to do on those weekends? Does it look like, what is work-life balance to you? Is it the ability to have family, not have family, do something other than medicine? What is work-life balance? And you find almost certainly that what they're really thinking about is they want to be able to do the things that they enjoy.
Yes.
In the end, that's really what it is.
Yes.
I want to be able to do most of the things I enjoy. So then I came up with the idea of, work like that your life is the cardboard box.
Okay.
And you get to put whatever you want in the box. It's not a balance. It's not one side against the other side. It's you've got a limited amount of space. Choose wisely as to what you put in the box.
And the box is a metaphor of time.
Finite space. Yeah,
okay.
Time. It's not only time, cognitive load.
Sure.
Some people need 12 hours of sleep a night. Some people need 4 hours of sleep a night. Whatever you've got to put in there.
Yeah.
You've got to put the stuff in.
Yes.
You've got to work out how it's going to work. And actually the contents of the box change all the time.
Yeah.
Your early 20s, there might be a lot of work in the box and a little bit of surfing and some sleep or whatever. As you have a family, there's going to be a lot of kids and a little bit of work and maybe some husband or partner or whatever. The kids move out, you're going to maybe have a new work life, second career, whatever. I've always, it's really important to be intentional. Don't worry about work-life balance. Be intentional about what you do in your life. Do not waste time. So it has to pass the deathbed test.
What's the deathbed test?
When you're on your deathbed, will you say to yourself, gee, I wish I spent more time watching Married at First Sight? Or even just, I wish I spent more time watching TV. Probably not.
Yeah.
But if you will, then put lots of TV in the box.
Got it.
But if you won't, then put the things that you're going to regret in the box. So, it's super important and so I don't commute.
Okay.
At all. I don't drive.
So that's not in the box.
It's not in the box.
Commute's
I
not in
don't
the
drive.
box.
I live
Drive's not in the box.
7 minutes from work. I don't have a television.
Okay. Married at First Sight out.
Married at First Sight, out of the box. I only know about it because you can't get away from it on the news. I only try and put things in the box that are enriching and that are things that I want to do.
Okay.
And of course, the balance is never perfect. It's never I've never have everything in the box that I want to do. But by not wasting an hour or 2 hours a day on driving to and from work and watching television, I go to a lot of plays. I read before I go to bed. I fit other things in that I think I will regret not doing.
Yeah, so I was going to ask, everyone's box is going to be different because everyone's goals are different. Everyone's deathbed tests will be different. So in your box, you have plays, obviously work. What else do you have in there outside from
Travel.
Okay.
I mean, my partner and I love travel and we do that a lot. And he's obviously there in the box as well.
Yeah.
Family,
Hi, Jeff.
lots of time with family, reading. And I take all my leave. I'm not one of those people who doesn't take leave. I probably take more than my normal leave, and we travel.
And do you think you managing the box so well, or at least so intentionally, helps you deal with the pressures of work?
Yeah, I guess so. Yeah, I mean, the pressures at work, you grow into them because, I think the main thing that helps me manage the pressures at work is to say, well, you know what, I can stop. I don't have to do any of this. So you have a bad day, you go home, have a sleep. You know that you wake up the next morning, it'll be okay.
So even the work component in the box is intentional.
Absolutely. I mean, I don't have to edit the journal. I don't have to do either of those jobs at all. I don't have to do Pangea. I'm sure I could hand that over to someone else. I don't have to do a whole bunch of things, but I decide to do them.
I'm seeing a little bit of a trend of the way you think and how it's propelled you to where you are today. Many of the audience that will be listening, I think one of the top searches actually on YouTube is stories of successful people and how they started. And I think so many young people are trying to normalize their experience, their difficulty on a journey of finding success with other people that have been on that journey before. I read somewhere that you were, during your surgical training, there were these exams that you had to take.
Yeah.
Right.
The part one exam, yeah.
Well, the funny thing is you mentioned that on this exam, if you do fail, they give you a percentage score on the likelihood that you would ever pass. And you got 1.5%.
1.5%, yeah.
So an official source
I wish I'd kept that letter.
has declared to you officially that, Kate, you have a 1.5% chance statistically of succeeding.
Yeah.
How did that make you feel, and how did you overcome that?
Well, look, I guess when I got that number, I thought I probably hadn't given it my best shot.
Okay.
So, I probably thought that. At my fourth go, I had decided if I did not pass, I was changing track.
1, 2, 3, fourth time you passed.
Fourth time I passed.
Wow. What kept you going at number 3?
Oh, I don't know. Because I wanted to.
That was it.
That was it. I mean, everything is just step by step. and what you can put up with. And, you know, I knew I enjoyed surgery. So this is all happening. I'm at work. I'm, you know, starting to work as a junior doctor. I'm starting to do operations. I'm starting to work, you know, more sort of autonomously.
Yeah.
I know I like it. I enjoy the team. You know, I enjoy the way of working. So I knew I wanted to do it. And so I sort of thought, well, I'll give it another crack. I mean, what am I losing? I was like 24, 25. I mean, another year, whatever. I was earning money, remember? So I'm working. Give it a crack.
Did you get a new percentage with every
No,
fail?
they stopped those letters.
Okay.
They got a little bit kinder. So, yeah.
So you got 1.5.
1.5. And
that was it.
That was it. I didn't get another letter.
And you have no idea whether that went up or down?
Well, I presume it went up.
Wow. Another thing that a lot of young up-and-coming people I find struggle with is the concept of risk. Mm-hmm. And taking a risk for the potential progression or regression of life, right?
Yeah.
And everyone's a bit paralyzed by that. I'm trying to put myself in the shoes of a surgeon, which is really hard. But with surgeons, there's always a risk because you go into the theatres, anything could happen and you try your best, but there's always a risk element. I guess it's a three-part question. First part is, how do you contextualize that risk and still move forward every time? Second part is, when you're in a surgery and something's gone unexpected and wrong, how do you navigate that? And I guess finally, in cases, I don't know if this has happened or not, but in cases where there's a negative outcome, how do you navigate that?
Okay, so I'm going to answer the question that you've not asked first.
Okay.
Which is,
I think I know what that is.
for me, risk is very different to what everyone else thinks risk is.
Okay.
Because for me, the risks that other people think about, no one's going to be dead, blind, or paralysed by the end of the risky thing that most people think they're doing.
Sure.
And so that makes you pretty comfortable about the other stuff in your life.
Yeah.
You know, and this is probably not the right way to deal with it, but, you know, I'll be working with researchers or whatever, and they'll come and they go, I'm so worried about this, and this is going to be terrible. And I'm like, is anyone going to be dead, blind, or paralysed at the end of the day? And they're like, no. And I'm like, okay, we'll deal with it. It's all right.
Yeah.
Don't worry. Oh, but it's okay. So it's probably not necessarily a good thing, because family members will be really worried about something, and I'll be like, what are you worried about? Like, nothing too bad can happen.
Sure.
So that's one thing. It makes you very aware of very different risks. As far as in surgery goes, I mean, you train to deal with the risks. That is what it is. And as long as you haven't done a bad job, most of the bad things that happen are known consequences. It doesn't make it easier, but you've probably weeded out the people who can't deal with that earlier in the training, because, you know, as you go through your training, you know, you see bad things happen. And if they happen because someone wasn't paying attention, because someone did the wrong thing, then it's very difficult to live with. But if they happen because they happen, then you learn to deal with it. Yeah. But, you know, there are times where I have a saying with, you know, my anaesthetist who I work with very closely, if the day has not gone as we hoped, that, you know, we're going out to go home and get our application to be night shelf stackers at Coles out again, because we just want to do something where no one will be dead, blind, or paralysed at the end of the day.
Yeah.
So it does get you down, but you have to, like, it's part of your training to learn to deal with it.
And I guess somebody's got to do it, because if everybody was stacking shelves at Coles at night, the patients that need you won't have you.
Yeah, and that's right. You know, you're playing a numbers game. Yeah. I mean, number one, I didn't give them the disease. I'm trying to help. Number two, you know, we've warned people of the risks up front, you know, and people, I say to someone, you know, you could die, you could have a stroke, and they're like, oh, you've got to tell me that. And I'm like, yes, I have to tell you that because it might happen. Yeah. And they're like, oh, like, this is not just a tick box. And I'm like, no, this is not just a tick box. You know, I'm not going to tell you that your leg might fall off, because that is not going to happen, but you could die. So I'm only trying to make things better, and in the majority of cases you can, but in a minority of cases you don't, and that can be hurtful, but it is what it is. And if I can't live with that, but we all hate it. There's none of us that sail through a complication and just don't feel bad. We all hate it. We all feel terrible.
And I guess it's your job to also handle that and then show up for the next patient.
Keep showing up for that patient
without a loss of enthusiasm or
with
hope.
all of those things. You've got to turn up and even be sorry. I am so sorry this happened to you. You know, I'm so sorry. And you know, we always say if someone's had a complication, normally I'd see my patients once, sometimes twice a day. If they've had a complication, definitely twice, sometimes 3 times a day. You know, you've got to be there with them in the problem.
You've mentioned that you have photos of certain past patients in your office to remind you of certain things that have happened. What's something that you could share there?
Quite often, in a couple of occasions, I've got photos of patients who've died, particularly people who I've looked after for a long time, you know, and you see them, you know, in a part of their life. There's, you know, one particular couple who, you know, their wedding was put off by you know, the diagnosis of the brain tumour, and then the wedding happened, and then their honeymoon was put off, and then the night before their honeymoon we had to start his chemotherapy. So he started chemotherapy in Paris, you know, and there's a picture of him and his wife in front of the Eiffel Tower all lit up, and it's lovely. And I look at it and I think, when I'm I'm not really having a bad day. Not really. You know, I'm okay. It's a bit busy today and things are a bit stressful, but I'm okay, really.
Putting things in context.
And I, you know, also gifts that have been given to me, not only photos, but gifts that have been given to me by families, either who've done well, which is encouraging, or who've died, and those things, you know, really sort of sustain you.
And how does your faith play into your role as a surgeon? Because you've mentioned before that part of the things in your box is you regularly attend church on a Sunday. And you feel that science and faith actually work together a lot of the times. How so?
Well, I mean, faith informs everything you do. I don't think it really matters whether if you have faith, then it doesn't matter whether you're a night shelf stacker or a neurosurgeon. You know, you're looking to live out your faith in what you're doing. I always feel a little bit sort of difficult talking about this because, you know, then all of a sudden you find yourself swearing and going on like a crazy person because something's gone wrong, and you think, well, that's not a very good example. But anyway, but the point is that your faith informs what you think is the right behaviour and the good behaviour and the way to do things well. I mean, you know, you have an example and you're trying to follow it. I'm very happy to hold in tension the stories from the Bible about scientific things and the science that we know is true, even if they're somewhat contradictory, and hold them sort of in balance and say, this is one way of looking at it, this is another way of looking at it. And a bit like C.S. Lewis when he said, you know, when we get to heaven, we'll have all this knowledge, and what we're going to say is like, of course it's like that. So I just figure that one day I will have all of this knowledge that will say, oh, of course, that's how they meld together. Like you don't have to be dogmatic about either of the things.
My wife would love that. She loves C.S. Lewis. So.
C.S. Lewis is the best. Some of the best ideas, you know. But that idea of course it's like that. C.S. Lewis is a good one for talking about time and why we always feel like we don't have enough time. And he says we don't have enough time because we were created to be immortal, and it's only when death entered the world that suddenly time was short. Limitation. Wow. So we're created to be immortal. So a fish doesn't complain that water is wet.
Yes.
Because they're created to be in the water.
Yes.
And the reason we complain about time is because we were not created to be in time. Now, whether or not you have any faith or you're Christian or believe in any way, it's still a great concept.
hearing everything, your journey and all the patients that you see, with all respect, I don't want to see you in a hospital. If you were to have a rough percentage, how much of the patients you see and the conditions they have, how much of that is preventable?
Yeah. So probably not as big a percentage as you think. Okay. So look, there's all the stupid things that people do with trauma.
Yep.
You know, e-scooter, not looking where you're going, no helmet, drinking a beer at the same time. You know, really.
Sure.
So, but still, you can be doing all the right things and have a car accident and still end up seeing me. It'd be really great if you didn't smoke, because that makes it more likely that you'll have a stroke or get lung cancer, and then the lung cancer will go to your brain. But it also is a risk factor for multiple other cancers. And I say this, you know, not judging anyone, because I'm an ex-smoker, so I know how hard it is.
Yep.
It would be really good if you maintained a normal weight, because again, that gives you a whole bunch of risks for cancers. But what people don't realise is it also makes you harder to look after in hospital.
If you're overweight.
Yeah. Increased risk of wound infection. All of those things, more likely to get blood clots in the legs.
Yeah.
So again, not trying to be judgmental, but it's often, you know, these are the downsides that people don't think about with, you know, being overweight. And overweight and smoking is particularly bad combination. We'd like you to do some exercise. Okay. Because particularly core strengthening to strengthen your back so that we don't end up operating on your back, but nothing's a guarantee.
You could get an injury.
Yeah, you can still get an injury. That's right. Yeah. So there's not a whole bunch you can do. I mean, the sorts of tumours that I mostly look after, like something called a glioma, you know, mostly it's just bad luck. So there's no magic potion, I'm afraid.
Yeah.
But if you could just stay generally healthy of a normal weight and not smoke, even if you do need to see me, things are going to be much easier for you. Okay.
So try and stay within a healthy weight range, eat well, exercise, don't smoke. What about if I'm very active and I play sports such as like rugby or soccer, where you headering the ball, does that...
Well, multiple concussions, you know, are not great, but you're not going to see a neurosurgeon for that.
Okay.
I mean, you might, but I mean, that's going to be a chronic process that will end up, reducing your cognitive capacity in the future. So you don't want to have too many concussions. Okay. But I'm not much of a policeman. Okay. You know, if you really, really, really need rugby football in the box for the work-life balance and for your, you know...
It's the deathbed test, right?
Yeah, yeah. So if you're really going to regret... You know, I get people who come and they... had a guy the other day. He's going to play in the World Masters AFL overseas, right? And he's got, you know, some spinal problems. And he's like, can I do this? And I'm like, well, yeah, like, go. Because like, and he's like, oh, I wasn't sure if I was going to be, and I'm like, you must go. Like, this is like what you see as the best thing that you can do. So go. So I think, you know, risk is always quite relative to what the patient or the person wants. You know, if you've got some dodgy discs in your neck and someone says, do you want to do bungee jumping, and we know that your neck's going to be thrown around and you're really not that keen on bungee jumping, then, okay, it might be a bit stupid. Yeah. But if you know, you're a star rugby player, or it's your bucket list or whatever, and it's really important, then I'm not a policeman. You can do whatever you like.
Context. Is there anything that I might be doing that I'm unconscious of that is helping me potentially see you in the future in the hospital? Like anything that people do unintentionally without knowing, like not the obvious ones, not smoking,
probably
exercise. Not. Okay.
Probably not. I mean, the dementia stuff, it's all coming out now that, you know, exercise, good diet, don't smoke, don't drink too much, and stay engaged with the world, you know?
So it's all... Everything comes back to the same.
It does. It really does. It really does. And, you know, obviously be safe at work, you know, be safe in sport, but you be safe on the road, but you can't take all of the risk away from that.
Common sense.
Well, common sense is not that common. I mean, the reality is that our life expectancy is going backwards. We have your generation is the generation that has, you know, should have the longest life expectancy
Yeah.
of any previous generation, but it's going backwards.
Lifestyle.
I mean, in the US, it's suicide, guns,
Yes.
opioids, obesity. In Australia, it's probably obesity, some other factors.
Yeah.
But, you know, the life expectancy is reducing, not increasing. It's the first generation in a long time.
Well, I spoke to a guy last week on this podcast, and he works with youth, and he mentioned that the highest killer with between 12 and 25 is actually suicide at the moment.
Correct.
And then if you live past 25, then where we source our food,
Yep.
the way we live our lives with convenience
Yep.
around every corner, that's not helping either. But it's not hard, is it?
Well, it's as hard and it's as easy as you make it. I mean, building exercise into your life shouldn't be that hard. And in Australia, the reality is, you know, people go, oh, it's, you know, so expensive to make good food and whatever. Carrots aren't that expensive.
That's right.
Neither's lettuce. It depends on how you look at it. And look, I understand some people have genuine challenges, you know, challenges with regards to the way they were brought up, with where they live, with, you know, all of those things. So it's hard and it's easy. But the reality is it's those things that we're not paying attention to that are the most important.
Yeah.
You know, you can suck down all the supplements you like and, you know, do all the other stuff. But if you eat well, you know, fresh food, low processed, not too much meat, you know, the stuff that we all know, don't smoke, exercise moderately to vigorously 3 or 4 times a week, you'll do well. Don't drink too much.
And then I'll just keep seeing you on podcast settings and not in the hospital.
Yeah, correct.
Now, I have here reviews, I think you'd call them, of people and how, well, stuff that people have written about you.
Oh, that's interesting. I don't read them. Because every so often people write really awful things. I got online once and one of the reviews, because I wasn't looking at myself, I was looking for the names of the rooms of another surgeon. Yep. And I came across one of my reviews and it said, "Don't see her, she is evil," in capital letters. And I thought, okay, I'm not going to read any reviews ever again because this is not going to be good for my mental health. So I didn't read them.
Look, there were a few questionable ones.
There always will be.
And I mean, I'm exercising a certain amount of empathy going, well, that person is probably unwell, or they have a family member who's unwell. They had some kind of expectation.
No, everyone has different styles of what sort of person they like.
Yeah.
You know, that's okay.
Yeah.
That's why people get to choose their doctor.
Sure. Well, the ones that I have here, they seem to have a common thread, and I'll read them out to you. Honest and firm.
Yeah, that's the thing that sometimes people don't like.
That's right. But this was spoken in a positive light. I disagree with her about my issue, but she explained her reasoning and discussed it with me. With controversial, rare issues, it doesn't mean the professor is bad just because they don't say what you want to hear, which I think is well put. Right. Another one said, very honest, positive energy, great ethics. I could never fault Kate Drummond. What a truly gifted doctor. So happy she's mine, probably my doctor. I couldn't go through what I did without her. Kate kept my dad going for 11 years with GBM, which is a brain tumour. She's incredible. Does this sort of, these messages make you get out of bed in the morning?
I know that there'll be people who so I know that there's people who are not going to like my style.
Yeah.
It's often people who've got, say, back pain or something where my message is what I've just told you, you know, lifestyle.
Yeah.
That's not so easy sometimes.
Yes.
it's more the face-to-face interactions, and they're often very positive with my long-term brain tumour patients. Most of those patients, I have a really good relationship with. And even in the end where people often seek 2, 3, 4 opinions, people might choose, someone else. It's a stylistic thing, and people are allowed to choose whoever they want. So, anyone who gets upset because someone chooses another neurosurgeon or whatever it is in life, because someone chooses someone else, I've got plenty of work, and you'd be pretty crazy to not allow someone that grace of choosing who they want. That's what we get to do.
And it's not about you at the end of the day.
No, in the end, that's right. It's not about me. I mean, they have to be wherever they are most comfortable.
Yeah. Now, Kate, to finish off the podcast, we have a tradition where the previous guest leaves a piece of advice for the next guest, okay, without knowing who they are.
Right.
So the piece of advice that was left for you, which I haven't read until now, and I always wish they have good handwriting because it's really awkward going sitting here for 5 minutes trying to decipher it. The greatest work you will ever do will be within the 4 walls of your home, your family. This will be the greatest legacy in the world. What does this mean to you?
So I don't have kids. So, I mean, the greatest work that I do is still within the 4 walls of my home with my partner. But I think the legacy that I leave, I would say, are the people I train. So, they used to call me Mother of Dragons until she went and torched everything, and I didn't like her anymore. So I pretty much the people who I train, I guess you could say metaphorically, without trying to be creepy, are my kids, and that's my legacy. So I see the people who I train and who become neurosurgeons as my legacy. And so it's not really in the 4 walls of my home, but in what I do, that is the most important thing. Yes.
Yeah. Amazing. Yeah. Well, Professor Kate, like I said earlier, your reputation of being someone that champions worthy causes is honest and firm, that does your utmost best to look after patients. It's definitely something that precedes you, and people who have not met you personally say that about you. And from our brief interactions, even just after your talk until today, I really feel a similar way. And so I just want to honour you for the great work that you do.
Thank you very much.
And thank you for being here today.
Thank you very much. But remember, I only get to do it because of the great patients.
Yeah.
They're really much more important.
That's right. It's all about the patients. That's what you keep saying.
It's all about the patients.
Yeah. Never about us, all about helping the people.
Yeah.
Yeah. Amazing. Thank you.
You're welcome.